Rule Replay town. Did you do that on purpose, Mariana? Good for you.
I wish I
Way
could
to
say I
post
did.
it. I hope that you had a lovely Valentine's Day, should you celebrate that day. And for everyone, I hope that you are safe and warm, given the weather that we're experiencing across Colorado today. I am Tom Miller. He, him, his are my pronouns, and I am the Division Director for the Quality and Standards Division within the Behavioral Health Administration. We can move to the next slide. Thank you. Before we move to some housekeeping items, I would like to point out our BHA values of truth, equity, collaboration, community-informed practice, and generational impact. If you have been in one or more of our preceding Rule Town Halls, you know that I start with each of these values and how they were present in our rule redrafting work. I also want to tell you that when we struggled with any stakeholder feedback, in particular, when we had feedback that took both sides of a particular issue, we reminded ourselves of each one of these values and proceeded with those rule changes based on what you see here on the screen. Next slide. Of course, again, welcome and thank you for being here, especially if you have been to some or all of our preceding town hall meetings. With that, let's start with staff introductions. These are the people that have worked so hard to make this project happen in an incredibly short period of time. And I would like to start with Victoria Lasky, who has done an incredibly fantastic job of leading the team that have been the primary rule drafters. Victoria.
Thank you, Tom, and good morning, everyone. My name is Victoria Lasky. My pronouns are she, her, and I am the Associate Director of Safety Net Licensing at the Behavioral Health Administration, and I am pleased to request that my team introduce themselves as well, and we'll start with Erica.
Hi, everyone. Erica Gannett, she, her pronouns. I am a Safety Net Licensing Manager and glad to be here with you all today. I'll pass it over to Mariana.
Thank you, Erica. Good morning, everybody. My name is Mariana Sears. I'm one of the Safety Net Licensing Managers. I will be speaking today a little bit about residential services, Chapter 9, as well as withdrawal management. And I will go ahead and hand it over to Mel.
Thank you, Mariana. Hello, everybody. I am Mel Tyler, she, her pronouns. I am a Safety Net Licensing Manager with BHA, and I will be talking about a portion of Chapter 2, Chapters 5, 7, 8, 15, and 16 today. Looking forward to chatting with y'all, and I will hand it over to Jenna.
Thanks, Mel. Good morning, everyone. Jenna Cap, she, her pronouns, and I'm also Safety Net Licensing Manager, and I will be talking a little on Chapter 2 as well, and then Chapters 13 and 14. And I'll hand it over to Olivia.
Hi, everyone. Thanks for being here. Olivia Zern, she, her pronouns, also a Safety Net Licensing Manager, and I will be presenting on Chapter 10, our crisis chapter, as well as Chapter 12, the emergency and involuntary subcommitments. Back to Tom.
Thank you, Olivia, and thank you, team. As always, this town hall is being recorded and the video will be posted on the website. I think I already saw a question about that in the chat. Can you help me out, Victoria, with how quickly we're able to get these recordings back to the website?
Yes, so we will be posting the recording. So it'll be the same as if you've been joining us for those town halls. We will be posting the recording today as well as the slide deck, and we're hoping to get that up next week.
Thank you for that, Victoria, and thank you for the question. As a Zoom webinar, and given the large number of participants, cameras and mics are disabled. So please use the question and answer function should you have a question, though we do have built-in periods, albeit short, after each chapter. Next slide, if you don't mind. So today is the recap of the previous 5 town hall meetings. As Victoria said, you can feel free to visit the Behavioral Health Administration Rules and Laws section of the website to see those draft rules, previous recordings of those sessions. And as always, you can submit your feedback through the feedback email posted here on this slide. And while formal stakeholder period is closed, we still record all input that we get and modify the rule language when appropriate as we move forward with the State Board of Human Services. But most importantly, we are going to continue to log that information and use it for future rule changes. Next slide. Here is what you can expect for today. The primary rule authors that you heard from a little bit earlier will lead you through a chapter by chapter review of the stakeholder feedback that we have incorporated into the draft rule. Some caveats. With some exceptions, we did this for comments received by January 11th of 2023. As I mentioned, we keep track of those comments received after January 11th, and we're using them for future updates. And again, in some cases, changes that we may make as we present to the board, and Victoria will talk a little bit more about that particular process. So again, for today, we'll be reviewing chapters 1 and 2 and 5 through 16. So before I turn it over to Victoria, here is some of what we have accomplished so far. We have had 5 town halls in December and January. Over 300 unique stakeholders attended those town halls, which basically means we didn't count any of you twice. I know lots of you were in more than one of those town halls. Over 600 comments were sent through the town halls themselves, feedback forms and emails that we had running during that period of time. And finally, we have met extensively with our partners at Healthcare Policy and Financing, the Office of Children, Youth, and Families, Colorado Department of Public Health and Environment, and of course, the Department of Fire Prevention and Control. Lastly, I will also add that many advocates and experts within the BHA themselves have contributed to improving these rules and improving the quality of mental health in Colorado. I think with that, over to you, Victoria.
Thank you very much. I'll take the next slide. All right, so Tom has just alluded to this, and then Dr. Medlock also mentioned, we are taking a different approach with this rulemaking timeline and wanted to provide this update to you all today. So we are currently moving forward with a 3-packet approach to our rulemaking, packet being the term of art we use regarding the materials that we submit to Secretary of State and the State Board of Human Services. So at this time, we are going to be presenting on what we're calling Packet 1, which is our behavioral health entity licensing chapters. This is because we have that prioritized deadline of taking on the authority for the behavioral health entity license by July 1st, 2023. So that's really first priority in terms of getting these rules promulgated. So this includes chapters 1, 2, and 5 through 16, which is the authority and definitions chapter, the BHA general licensing chapter, as well as the endorsement chapters that would attach to that BHA license. The notice was filed at the end of January. On my next slide, I'll give more information about how to find that notice in that rulemaking packet. We are anticipating a first read, what is called a layover reading at State Board in March. We will be taking 3 readings with this packet because this is a quite large, I think we all understand the volume of rules, especially if any of you were in those town halls. So we are anticipating 3 readings at State Board to make that information more digestible. in order to meet that statutory deadline of July 1st, 2023. So what that looks like, in order to make that more digestible, we've broken it into these 3 different packets. So what we're calling packet number 2 is our safety net approval and care coordination. Those are chapters 3 and 4. That is not yet filed. As Dr. Medlock mentioned in the chat, we are taking a different approach, allowing for some more time on those chapters, and we will have further updates about the timeline for those in the future. Packet 3 will be our other licensing and designation pieces. So that includes our controlled substance license, our Recovery Support Services Organization license, our 2765 designation for involuntary services, our residential child care facility endorsement, and BHA administered programs. For those who've been following along at home, those are chapters 17 through 22, and those again have not yet, the notice has not yet been filed, as we are looking at a different timeline for those in order to, again, make this more digestible and prioritize BHE. Next slide. So what is done as of today, February 15th, 2023, our notice was filed for rule packet number 1 with the State Board of Human Services on January 30th. So we have our assigned tracking number for that, again, including our BHE chapters 1, 2, and 5 through 16. This packet is publicly available. It can be found on the Secretary of State's website. We have a link here in the slide that will be available. I see Mariana has also chatted the link here. I also want to emphasize that this is our notice of rulemaking. So this is not our very final version. We are actually have the opportunity to submit another version of the packet by February 22nd. Of course, not anticipating major changes, but still doing some tweaking behind the scenes to make sure that's ready to go for our first reading on March 3rd. And then there will be, throughout the rulemaking process, we'll have our 3 readings, our first in March, our second in April, and our third in May. And really rule changes can be made to these rules up until that hopeful adoption date in May. So I say that just to make sure we're all on the same page as far as what has been done so far and what is still left to do and what the timeline looks like for that. So you are welcome to take a look at that rulemaking packet. I will warn you, it is a very large file. It's coming in at about 1,100 pages, and don't worry, that's not all rule language. That is including the format of the packet, which includes our full stakeholder comment and response. So anyone who has submitted a comment, either in a stakeholder meeting or through our inbox or through our form, we do have a written response to all comments provided. That is included in that packet, as well as what really makes it so long is there's this table where we have to put the old rule language and then the proposed rule language. And so fitting that much rule language into a little table does tend to up the page count. So you will see at the very end of the packet is just the clean rule language. That's the easiest if you want to see what is the current proposed rule language. And then there's additionally, will probably be of interest, especially if you've been engaged, those responses to comments. So that's the notice. And again, there will be an updated packet that will be finalized by February 22nd as well. All right, I'm seeing some chats coming in. I see a question about the layover reading, and is this an event that the public is invited to? Yes, it is. So this is part of the State Board of Human Services regular meeting on March 3rd. At the very end of the PowerPoint, I've got a link to the State Board of Human Services webpage. We could have someone drop a link to that in the chat. It includes information about how to join on Zoom. It's also in person. Anyone is welcome to join that. It is a publicly open meeting, and you can see us go through our layover or initial reading of these rules, again, anticipating a 3-read throughout the spring. All right, well, with that, we can start diving into our rule replay, again, going chapter by chapter, and of course, starting with chapter 1, general statutory authority and definitions. So overall in this definition section, we have increased alignment with definitions in statute. So of course, this is very important. We want to make sure that all of our definitions are as aligned as possible with statute to reduce confusion. So we have gone through and made some changes there in order to increase that alignment. Some definitions were added to increase clarity, and those I will be highlighting. And then also just another update. So throughout the rule volume, there are these parts called incorporations by reference, where we have to reference where our address is so that the public knows where they can access printed materials of that reference. And it includes an address. As of tomorrow, we will be moving from our Fort Logan campus to the CDPHE Colorado Department of Public Health and Environment campus in Glendale. That's starting tomorrow. So you will see that the update is now updated to that new address on, I believe it's Ash Street. All right, so we did make some changes, some adjustments to the child and youth definitions. I'm just briefly mentioning this now. Jenna, when she goes through chapter 13, we'll talk a little bit more about this, but statutorily, child is defined as under 18 and youth is as under 21. So we made sure that those definitions were aligned. A definition that was added was the Psychiatric Advance Directive, or PAD. PAD means a written instruction created pursuant to the CRS citation concerning behavioral health treatment, medication and alternative treatment decisions, preferences, and histories to be made on behalf of the adult who provided the instruction. This actually came up in one of our stakeholder town halls. We had stated advanced directive in the rule and received the feedback that that was unclear. Was this a medical advanced directive? Was this a psychiatric advanced directive? And so this definition was added and is used throughout the rule volume to increase that clarity. So we also have this added definition of provider organization. And the reason that this definition was added, and I saw, I think Dr. Medlock had mentioned in the chat, being more specific about that BHE applicability. This was really added to attach to the behavioral health entity, or BHE definition. So in chapter 2, there is language about who is subject to the BHE licensing requirement, and those are in 3 categories. One are behavioral health entities currently licensed by CDPHE. Another is agencies currently designated by the Behavioral Health Administration. And the third is agencies including substance use disorder treatment that are approved by the Behavioral Health Administration. So those fall under the BHE licensing requirement. And then there was additional questions about if you're not falling into one of those categories, then are you meeting the definition of a BHE? And so this was added to increase that clarity. So I'll read this aloud in case anyone's joining through the phone. Provider organization means a corporation, partnership, limited liability company, business, trust, association, or other organized group of persons, whether incorporated or not, which is in the business of behavioral healthcare delivery or management. And that includes 10 licensed or certified personnel providing behavioral health services to individuals. The exception to the 10 provider requirement is any size organization providing 24-hour or overnight services. So we did include this definition to increase some clarity around the BHE license requirement. Here we've also included the 72-hour emergency rule, which refers to the DEA's regulation that allows qualified practitioners to provide controlled substance medications to individuals experiencing acute opioid withdrawal daily for no more than 3 days. We'll be hearing about that a little more in the withdrawal management chapter. And then also added the definition of recovery, which was borrowed from SAMHSA, the Substance Abuse and Mental Health Services Organization, which means a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. Another note, so those those of you who have seen this definition in our first draft wanted to highlight that we have removed this definition for certified community behavioral health clinics, or CCBHCs. We had this definition kind of hanging out there. Originally, there had been some thought about maybe incorporating that into the rule in some way, and that was not moved forward. And then we still had that definition there, which wasn't being used. So we removed that in order to increase clarity. There is no reference to CCBHCs in the rule volume at this time, but I also want to highlight that the BHA is participating in the state of Colorado's application for the CCBHC demonstration, and that's how we're kind of moving forward in the CCBHC realm at this time. All right, I'm going to hand it over to Mariana to highlight a new section of our definition section, which we're hoping will increase a lot of clarity about personnel throughout the rule volume. So Mariana.
Thank you, Victoria. Hello again, everyone. So yeah, I think one of the things that we've received feedback from multiple stakeholders across multiple chapters that we took some time to really focus on and figure out how we could provide some of that clarity was specifically around personnel. We realized looking through the definitions that we had, personnel was interspersed throughout since we were going alphabetically and might be difficult to find. And there were so many personnel definitions that it may have been challenging at the time to figure out how this would build across chapters and how we could be consistent. So we absolutely wanted to bring in the stakeholder input of making this more consistent, having a consistent personnel build across chapters and just making this more user-friendly. So we did add an additional part 1.3 that is specifically focused on personnel for all of the chapters that we are putting forward. So one of the things that we wanted to do, as we mentioned, is make sure that we're building on statutory definitions that already exist as the starting point, and then making sure that we can build in other areas where we can have that consistent kind of, this is what this means, going back to that first chapter, and then if there is something that is specific to a certain chapter, having it live there. So we did attempt to also move any misdefinitions that were relevant to 2 or more chapters into this section as well. So hopefully we caught all of those. So one of the ones that I will highlight here is authorized practitioner. And again, this we did get some feedback around this particular existing definition that we had to make sure that it was fully encompassing what an authorized practitioner really should be. So we have it defined now as the person who's authorized by law to prescribe treatment, medication, or medical devices, who holds a current unrestricted license to practice and is acting within their scope of such authority. This includes, but is not limited to, physician, psychiatrist, medical doctor, osteopathic doctor, physician assistant. I do want to highlight that one because that is one, as we go through some of these chapters, we did hear specifically, can a physician assistant be considered treatment staff, and why does that not exist in current rule? This is one way we can get that in there without with causing hopefully a little bit less confusion, as well as an advanced practice registered nurse, an APRN. So we will take a second to highlight the APRN specifically, because you will notice when you look at this section that APRN is explicitly listed underneath authorized practitioner, but it also exists as a standalone definition. That was meant to support the standardization of Chapter 1 as the main section for definitions. So that way we can have a consistent build across all of the chapters, but it also allows for this specific type of practitioner to have its own definition when the scope of practice may not match necessarily that existing definition. So for example, in Chapter 2. So as you can see here, we did include the definition of an advanced practice registered nurse and the standalone definition that can be utilized as applicable across the rule volume here. Moving a little bit forward with that, we did receive some feedback around that consistency of the build with candidate, counselor in training, licensed mental health professional, and this is how we've responded to this as well. So candidate, the definition still stands here. We just made it a little bit more abundantly clear what that means and who, what title they would be subject to. And counselor in training means the person currently in the process of obtaining a behavioral health focused credential pursuant to Part 8 of Article 245 of Title 12. Counselor in training will include interns, but does not include candidates as referred to in Part 1.3.5. And so this is one of the ways that we're hoping to make sure that we can more clearly delineate which type of professional person fits within which category as we're building ratios and different things across chapters. So with that, you will notice we have added specifically certified addiction specialist, certified addiction technician, and licensed addiction counselor as their own standalone addiction counseling focused personnel definitions, and they will build across chapters when you look at the proposed language that is put forward. The definitions that we have put forward are based on the personnel's certification or their license that is actually issued by DORA and meant to align fully with the personnel scope of practice per Part 8 of Article 245 of Title 12. So this is a little bit different, and I do want to highlight this. The first iteration that we put out had a slightly different definition of licensed mental health professional. It included psychologist, psychiatrist, licensed clinical social worker, a licensed marriage and family therapist, an LPC, and the first iteration that we put out did include a licensed addiction counselor. Again, looking for that consistency across chapters and bringing this back to existing statute to figure out how to better align. This was the better definition that we were able to come up with, and then adding the standalone definition of a licensed addiction counselor, we can then add that to every area, every relevant chapter where we want to continue building up that personnel definition to capture all of the licensed professionals that are able to provide the service. And at that point, we have reached the end of chapter 1. I will go ahead and hand it back over to Tom to field some questions.
Thank you very much, Marianne. I appreciate that summary of the chapter. I think we've gotten a couple questions about the rule packet submitted, and maybe it goes to the packet, maybe to the summary, and maybe not to the content itself. But Victoria, I think you found a solution for that.
Yes, so I am typing this out, but I will also say this verbally. So we have this is the link I'm going to drop into the chat, is where you can access the packet. And it's not completely intuitive, so if folks are interested in this, maybe we could take a minute and you can open up a new tab and get this download going. So you'll click on that link. This will take you to the Secretary of State website. If you look down under proposed rule, you'll see a gray line that says rule, and then there's a document that is proposed rule attached 2023-00076. I see. Oh, thank you so much, Mariana. Even better with a visual demonstration. So you will click on that, and that will download a Word document. Again, a very hefty Word document. I already described why that's the case. But you will download that Word document, and then that will open up the draft, the rulemaking packet. So you'll see on Mariana's computer, it's downloading. You'll see that's our cover page. So that is exactly how you access the rulemaking packet. Again, this is technically the notice. This is not final rule language. And there will be some minor tweaks before the State Board of Human Services reading, but you'll see that table I described with the old rule language, the new rule language. If you keep scrolling, there's the public comments and responses. And then at the very end is our clean rule language. Again, you'll see this is quite the document. So that should help you all access that.
Thank you very much for that, Victoria, and Mariana, for pivoting to that. I'm so glad that there are people with technological expertise on the team, because what you just said would way beyond my technological skill. Victoria, rather, are there other questions or pause for question time?
Yes, so there's one question that we received. Are RSSOs, Recovery Support Services Organizations, those are peer support professional-led organizations providing recovery support services, are they considered provider organizations? For the purposes of this, they are not. They are still considered that separate licensing for RSSOs. And again, the RSSO license chapter is staying as is for now. And then we've got that in our rule packet 3. So RSSOs are not subject to BHE licensing and therefore not included in that provider organization definition. I see one more question. I've got two more questions I see right now. Can you provide information about where this definition for provider organization is located in the rule package? I see the reference in the response to feedback, but not in the actual rule draft. So if you open up that Word document that Mariana just opened, the citation is 1.2.81. So that's where you can find the provider organization definition in the rule packet. All right, let's see, how are we doing on time? Are we needing to move on?
Let's go ahead and move to the next section of rule if you want to. There we go.
All right, me again. So I will be going through some of the changes made in Chapter 2, General Behavioral Health Licensing Standards. So this is applying to agencies required to be licensed as BHEs. So as I described earlier, Chapter 2 starts out with describing those categories of if you were previously licensed by CDPHE as a BHE, approved by the BHA as a SUD provider, or designated, and then added that provider organization definition on top. So that's who this applies to, and we'll walk through some of the changes that have been made in this chapter. So overall, we are doing a lot to really be more consistent with our terminology. So stakeholder input we received, and this is the format that we'll be using today, is starting with stakeholder input we received, and then moving into our response and change that was made. So we received input that the interchangeability of terms like agency, facility, licensee, applicant in one category, and then staff, individual, and person is confusing. So point well taken, we have created additional consistency in our term usage. So throughout the rule volume, you'll now see that agency is a general term referring to a provider licensed, approved, or designated by the BHA. Personnel is how we are referring to agency staff. Individual is referring to a person receiving or seeking services. And then person is someone who does not fall into either personnel or individual. That doesn't come up often as a need, but there are cases in which we need to talk about a person and individual, but we aren't referring to either personnel or an individual. All right, so another piece of stakeholder input, and we actually received this from several stakeholders, so we understand this was an important issue to you all, that some responsibilities that were listed for the governing body are better suited for an executive leadership team. And so to increase that flexibility, we added this provision in part 2.3.4 that the governing body may, at their discretion, delegate responsibilities in part 2.3.3, which is that piece of responsibilities that stakeholders were responding to. Those responsibilities may be delegated to an executive leadership team in order to increase that flexibility for providers. We also received stakeholder input that requiring the governing body to review all policies and procedures annually is overly burdensome. And a recommendation was made to change that to a review of any changes to policies and procedures that is reviewed annually, so any changes. And then a full review of all policies and procedures has been moved to an every 3-year requirement, again, with the intention to reduce some of that burden on the governing body of the BHE. All right, here we've also added under governance the requirement for policies and procedures for administration of opioid antagonists, and added that if the agency has an automated external defibrillator or AED, personnel shall be trained in its use, and it shall be maintained in accordance with the manufacturer's specifications. So both of these added to increase safety for those who are individuals being served in the case that they would need to be administered an opioid antagonist, and if they would need medical attention through an AED. So we received some feedback on our Part 2.4 personnel that a national background check should be an acceptable substitute for individual state background checks for state and an individual has lived in. So we had this and a lot of Chapter 2, I know I said this during our initial town hall, but just to reiterate, a lot of these BHE licensing standards are coming to us from CDPHE. We had the opportunity to make some changes. However, these are largely coming over from CDPHE, and this was one of those in particular. So in order to increase flexibility, we included that a national criminal history report conducted by the FBI would be a suitable alternative to having that individual state background checks for individuals who have lived outside of Colorado. So there was also a lot of feedback about this background check process and requirement, and particularly how that intersects with our peer support professional workforce that may have had justice involvement as part of their lived experience. And so the BHA has never taken a stance and said, these certain convictions would preclude you from all employment or anything like that. The agency creates that background check policy that is subject to approval. And that we just heard loud and clear that we needed to be very clear that when talking about peer support professionals, that should be taken into consideration when hiring for those positions, because a person's lived experience may have involved criminal justice involvement, and that could actually be a value add to the services that they're providing to individuals. So we have here the factors. So this language was not new. So there are policies and procedures around factors to be considered when determining whether a position is eligible for hire when their criminal history check reveals a conviction, which is not limited to the nature of the position and how the offense relates to the duties of the position, including whether the position is a peer support professional position for which an individual's lived experience may have included criminal justice involvement. So we just wanted to be really clear and call that out in this place per stakeholder feedback. There was stakeholder input that the tuberculin skin test requirement should be limited to personnel with direct contact with individuals. The BHA agreed and included this language that all personnel that have direct contact with individuals shall be required to have that TB skin test prior to initiating that direct contact. All right, so an additional piece we received feedback on was this record retention piece. And this was actually something that came over from our current rule volume. And we find currently is what we have in the rule volume is not quite aligned with statute. So this is an update that definitely needs to be made. So there was this feedback that is not aligned as far as for inpatient or residential agencies. So we did align with statute. So what is required by statute is that agencies providing outpatient services shall retain those records for 7 years, and those providing inpatient services shall retain those records for 10 years. So we broke out our endorsement categories into outpatient endorsements and residential or overnight endorsements. And we have that separate requirement so that that's better aligned with statute regarding how long those records need to be retained, including those specifics for when the individual is less than 18 years old. So there was feedback in the dispute resolution section, part 2.8, a desire for increased accessibility to the notice regarding dispute resolution, which is agency internal, and grievances which come to the BHA. So both the notices for dispute resolution and grievances added the requirement that the notice must be translated into languages commonly used by the populations in the service area and must be provided in writing and electronically, if applicable, if the individual is using electronic means to receive email communications upon admission to services. So again, increasing that accessibility so that individuals know what their rights are in order to file a grievance or engage in or report a dispute. So here in part 2.9, individual services, we received stakeholder input. This is where we really detail the telehealth policy, which current state we actually do not have any regulations specific to telehealth. So we are building those regulations in, especially in this COVID-19 world where we have agencies increasing their telehealth options. There was really this need to put those regulations in place around telehealth. So there was stakeholder input that it should be very clear that individuals have a choice, that telehealth is not the best modality for each individual, and just make it clear that there is that choice aspect. So language was added that says, if an individual prefers to receive services in person and the agency does not offer the appropriate service in person, the agency shall refer the individual to another agency that offers the services in person. There was also stakeholder input that we need to make clear that all agencies, not just BHEs, must follow telehealth requirements in Chapter 2. This isn't the most relevant for today because, again, we're really focusing in on BHE, but we did add to our endorsement chapters that requirement that they follow telehealth policies and procedures in Chapter 2 to catch other types of agencies besides BHE that we regulate. All right, and I will hand it over to Jenna to talk through our screening assessment and assessment pieces.
Thanks, Victoria. So yeah, I'm going to talk about the screening, initial assessment, and comprehensive assessment in part 2.10 of Chapter 2. So one of the questions or stakeholder input was to remove the requirement to ask for individuals' healthcare providers during the screening and move that to the assessment criteria. And then also within the screening portion, add for screening for behavioral health symptoms. And so what we did, we added or we incorporated that feedback. And so now in 2.10.1C3, we've added current behavioral health symptoms as applicable, including severity, duration, mental status, and changes or impairments in functioning due to symptoms. And then we did move that ask of an individual's healthcare providers to the assessment criteria, no longer in the screening portion. Along with that, there was concern over who needs to complete the screening and the requirement, and then there was a requirement that all screenings must be reviewed and signed by a mental health professional. We provided a little bit more clarity as that was a little confusing of who could conduct a screening and then who needed to sign off on it. And so in 2.10.1a, it says personnel meeting qualifications under part 2.4.3 shall complete a screening and triage process to determine urgency and appropriateness of care with the agency, including the need for emergency or urgent medical or psychiatric services. And then in addition to that, in 2.10.1d, we added screenings identifying imminent risk must be reviewed by a licensed mental health professional in accordance with part 1.3.18, a licensed addiction counselor or a LAC in accordance with part 1.3.17, a certified addiction specialist or CAS in accordance with part 1.3.9, or a candidate in accordance with part 1.3.8, performing within the scope of their practice. So just cleaning that up a little bit and making it more clear over who needs to review and sign off of the screenings and when. And then stakeholder input was to, there was a desire to make timeline requirements for the initial assessment and comprehensive assessment more clear. And so what we did was we added in 2.10.2a and then also at the end of 2.10.3a, which is the initial assessment portion and then comprehensive assessment portion, that agencies must meet timeline requirements set forth in applicable endorsement chapters and then see those endorsement chapters for additional requirements. And so I'm going to go through those briefly. As I said before, they are now moved into those endorsement chapters, but I'm going to go over those briefly here in a second. So this goes through the initial and comprehensive assessment. We tried to break it down and make it more clear because originally it had said 60 days within the comprehensive assessment part. And so we realized that that was causing confusion based off of certain endorsements and chapters of what they were requiring. So in Chapter 7 for ACM 0.5, they do not need to complete an initial or comprehensive assessment. In Chapter 7 for outpatient 7.3 or ACM 1.0, if the screening identifies an urgent need, the initial assessment must be completed within 1 calendar day, and if not urgent, within 10 calendar days. And then that comprehensive assessment will be within that 60 calendar days of admission. For Chapter 8, intensive outpatient program 8.1 or ACM 2.1, so it's the same and same with partial hospitalization 8.2, that part 8.2. Those are all going to be, if screening identifies an urgent need, the initial assessment must be completed within 1 calendar day, and if not urgent, within 10 calendar days, and then that comprehensive must be completed within 60 calendar days. So moving into Chapter 9, low acuity residential, initial must be, or sorry, I'll go through what is, so I'm not repeating over and over again. So for low acuity residential, including ACM 3.1 and 3.3, and then medium acuity and then high acuity, all of those for the initial assessment must be completed within 24 hours of admission, and then the comprehensive within 10 calendar days of the initial assessment. And then mental health transitional living home is the initial assessment is prior to admission, so it's part of the pre-admission assessment located in the endorsement portion endorsement chapter, and then that comprehensive assessment must be within 10 calendar days of admission. So Chapter 10 for crisis stabilization unit, it's within 24 hours of admission for that initial assessment. And then also same for the comprehensive assessment, that must all be completed within 24 hours. For walk-in crisis in Chapter 10, there is a crisis specific assessment. They are exempt from the Chapter 2 comprehensive, and so that's walk-in crisis will be following that crisis specific assessment requirements. And then Chapter 11 for withdrawal management, the same is for both level 1 withdrawal management and 2. And so it's upon admission for the initial assessment, and they're asking for the addiction focused history and physical exam. And then it's not required to have the comprehensive assessment. And then I believe this is the last one. So for 3.2 and 3.7, it has what 1 and 2 had, and then also in addition to that, within 72 hours of admission, the initial assessment must be completed and updated to relevant paperwork, and then that comprehensive assessment is not required. And then for DUI and DWAI, it aligns with ACM level of expectations for both initial and comprehensive, and same with criminal justice services. And then the last stakeholder input for clarifying who can complete a comprehensive assessment and if it needs to be signed, we added a little bit more clarity around that. And our response in 2.10.3a is the agency must complete a comprehensive best practices person-centered assessment signed and approved, so still including that signature, signed and approved by a licensed mental health professional, a licensed addiction counselor, a certified addiction specialist, or a candidate in accordance with their specific parts, performing within the scope of their practice. And then agencies must meet that timeline requirement set forth in applicable endorsements. And so see those endorsement chapters for those requirements, which is what I just went over. And then I believe I'm giving it back to Victoria.
It actually goes to me. Thanks so much, Jenna. I am going to talk to y'all about the changes that we made to this particular section of Chapter 2, the protection of individuals from involuntary restraint or seclusion. So we have this section in Chapter 2 for BHEs, and then we also have it in Chapter 17 for those facilities with 2765 designation for involuntary services. And what we found in the first go round of our rules is that we had differences between those two sections. So to add continuity and clarity between those two chapters, we took the seclusion and restraint section, which is part 17.5.6 that you can find on our website that has the rule chapters. And we took that and we put that also in Chapter 2. We updated the language to reflect that it is for BHEs. And that way we were able to have that consistency in those sections. So what this now includes in chapter 2 is clear definitions of what restraint and seclusion are, when it is appropriate to do those, and then also reasons when they may never be used. We've increased personnel training, and that includes things like making sure that the personnel are trained on safety measures when using these emergency interventions of seclusion and restraint, and also things like non-physical interventions, so de-escalation techniques, mediation. We have added in standards of admission at care. So this includes assessments for assault and trauma history, seclusion and restraint history, and also hearing from the individual on their identified strategies to avoid emergency interventions. We have added more specifics around the orders for seclusion and restraint and further assessments for that seclusion and restraint intervention. We've added in more information around observation regulations during these interventions to keep these individuals safe. We've also added in specific documentation requirements and a debriefing section. And then there is also language that we adapted from federal law around procedures for youth. And so those are the changes that we made for this section of part 2.12. We can go to the next slide, and I am going to hand this over to Erica.
Thanks, Mel. For 2.13, which is medication administration, there are a few changes that we made. So we received input from stakeholders requesting clarification of where administration rules apply to all personnel, specifically nurses were called out in a few comments, and not just QMAPs. And then also a request to add pharmacists where applicable. So wording was adjusted in part 2.13 to reflect applicability of all of these rules to personnel administering medication. So that includes nurses, QMAPs, and any other personnel acting within their scope to administer medications. We also specifically clarified in the medication disposal section that pharmacists are included through this adjustment that we made that says otherwise authorized to administer or dispense medications, given that that disposal is part of the dispensation as well. And then where pharmacists are acting on behalf of the agency and able to perform administration tasks per the scope of their professional practice, they are included and subject to all of these administration rules. So that has all been clarified. And I will pass it over to, I think, Mel and Mariana.
Thanks, Erica. Hello again. So I'm going to talk to you all about a brand new section that has been added to Chapter 2. This is created to support new legislation, which is House Bill 22-1236, that created the fentanyl and other opioid use disorder education program. And it also in the bill calls out education and treatment for fentanyl and other opioid use disorders. This will be required for all agencies providing services for treatment of substance use disorders, including fentanyl and other opioid use disorders. From this section, it created a new definition, which is fentanyl education, which means the fentanyl education program developed by the BHA pursuant to 2780-128 Colorado Revised Statute. So these referrals will come from the criminal justice entity. So these individuals are mandated to complete the fentanyl education program, and then they will be screened to see if they will need additional treatment by the agency. The agency will verify and document completion of the court-ordered education program. And I can park here for a second and tell you a little bit about the program. And Mariana just put the link to the information for it in the chat. So it is fentanyledcolorado.org. It is free for everyone. It's usually average about 1 to 2 hours to complete, and it is available to anyone who would like to complete it. So for agencies providing this treatment, this is a really great training opportunity for their staff to go through this education program as well. And that way they can see what is required of these individuals that will have to complete it, so they can help if needed. So these agencies will verify and document the completion of this court-ordered education program within 2 weeks of admission into treatment. Now, if the individual is struggling with completing it, the agency will then come in and assess the individual with getting it done. With working with fentanyl and other opioid use disorder individuals, support systems are super important. And so one of those that we call out in this section is medication for opioid use disorder, or MOUD. The agency must be capable of delivering MOUD through either direct service provision through the agency or through active collaboration with another MOUD capable agency. Opioid antagonists are also key for keeping these folks safe. And so these agencies must have opioid antagonists available on site at all times, and staff need to be trained in how to administer. They also need to be made available to individuals receiving treatment to keep on their person or take home. And these can be provided directly through the agency or through coordination with another resource. All agencies receiving this treatment will receive education. All individuals receiving treatment will receive through the agency education on how to administer opioid antagonists. And the agency also needs to promote or directly provide education to the individual support system with the individual's consent to have their support system involved. And I'm going to hand it over to Mariana to talk about training and competencies.
Awesome. Thank you, Mel. So I will go ahead and close out this section regarding the fentanyl education and treatment. So one of the parts that we put in here was it's really important that all of the personnel that are involved in the agency are trained to use the opioid antagonist and recognize symptoms of drug overdose. So that could be, the support staff who is at the front desk and making sure that everybody who's involved in this direct care and is actually dealing with individuals that are coming into the facility is able to recognize those signs and symptoms and knows how to respond. Moving forward into the personnel that are providing the actual treatment and the peer support professionals who are providing the supportive care, that they are trained and are able to demonstrate competency in the following areas. And these were developed in collaboration with the state SOTA to figure out, how can we make this as meaningful as possible and make sure that these services and these training elements are really capturing what the best practice would be for individuals providing services. So the areas that we have highlighted here, substances of misuse and dependence, the pharmacology of medication for opioid use disorder medications, cultural competency, which is extremely important, related to current misuse trends for opioid involved individuals, and focusing on harm reduction and trauma-informed practices in the treatment of opioid use. So as Mel mentioned, individuals that are referred into this education and treatment process are required to attend as a condition of probation. So the expectation there would be for the agency to communicate regularly with the referring criminal justice entity for the period of time where their fentanyl and other opioid specific services are determined to be clinically necessary. And this is where we really want to highlight who's able to determine that clinical necessity. So the licensed mental health professionals that we looked at a little bit earlier, as well as a licensed addiction counselor, a candidate, or a certified addiction specialist, again, all of these operating within their scope of practice and their training. So for that period of time, once the clinical necessity is no longer determined to be active and the condition of probation no longer applies, the requirement or the expectation for communication with the referring criminal justice entity would cease at that point. That does not mean that the communication absolutely has to stop. We really want to empower the individual at that point to determine if they still want to continue some of that communication, but this does allow the individual to continue with the treatment that is best for them. But once they have reached that point of clinical necessity and the condition of probation has been met, that we are empowering the provider to notify the probation officer or the referring criminal justice entity that they have met their condition of probation at that point. And as always, all of the communication that we're discussing here requires the written permission from the individual and making sure that we are following their wishes as well. Okay, we are at another question section, so I will hand it back over to Tom.
Thank you very much, Mariana, Mel, and all. I think that we had a few questions that came in the Q&A. The first goes back 20 minutes or so. So Mariana, I apologize for putting you on the spot. Could you go back to that particular slide so we refresh everyone's recollection about Sarah, and forgive me if I'm mispronouncing your last name, Sarah. I think it's Mallet. Your question, does 2.10.1A mean that admissions staff screening patients for care have to meet qualifications of 2.4.3? So that's the particular slide I'm looking for, Mariana.
Okay, forgive me for 1 second. I just stopped my screen share. I'm going to find that and then I will pull it back up for you.
Thank you very much. And while you're doing that, I believe, Victoria, you were prepared to answer that one. Also, just to give Marianne a little bit more time, I think we did also have a few other questions that were in the Q&A. So if I could add, Victoria, to your agenda for answering, what is the definition of urgent for assessment time period? Is that decided by the clinical personnel that comes in from Pam Treelor? And then once again, I apologize if I'm mispronouncing folks' names. And then I think we have a second question on previous slide 37, how is urgent defined? So we can knock out two with that particular one. Mariana, that's as long as I could stretch. That's me getting you back for the turning on the recording while I was doing my opening remarks. Now we're
Seems
even.
fair. I think I'm nearly there. I'm just trying to confirm which slide number it is before I share it.
Sure, Victoria, maybe you could answer the definition of urgent while Marianne is doing that.
Yes, so in rule, we don't specifically define urgent. Pam got it when she asked, is that decided by the clinical personnel? So that is up to their clinical discretion as far as what is being determined as urgent. So I think that answers both Pam and Melissa's questions. And this was the question regarding the personnel for screening under part 2.4.3. And again, that question was, does that mean those staff, those personnel have to meet those qualifications? And yes, it does. For those who are following along, part 2.4.3 is fairly broad language describing that people must be operating within their scope of practice based on their training and qualifications and current credentials. So this is not a very prescriptive description there. But really being clear, we know that there's specific training for specific screening tools and things like that. So that's really what that's getting to, is that folks are operating appropriately with a current credential within their scope.
Thank you all very much. I'm not seeing any other open Q&A questions. So perhaps we can move on to the next section.
All right, and I think we'll be going to Mel with chapter 5 once we get our slide deck back and going. Thanks, Mariana, for navigating all that.
Great, thank you so much. All right, chapter 5 review is outreach, education, and engagement services. This applies specifically to comprehensive community behavioral health providers. Now, Mariana, you can go ahead and go to the next slide. We didn't have a whole lot of feedback, but what we did receive was meaty, and it was excellent because it gave us great direction for this particular chapter. So one piece of stakeholder input was to ask to include language about reduction of behavioral health disparities. I was very excited to see this and love this idea. So I added it specifically to the definition to make it prominent. So as you'll see here in 5.1.1, outreach, education, and engagement services means focused efforts by an agency that have identified priority population and service needs in the agency's community that require levels of active engagement to produce positive behavioral health, positive behavioral health outcomes, including a reduction in behavioral health disparities in access to and engagement in care. Another piece was around the community assessment portion, both in increasing other avenues to obtain the community assessment and increase the reassessment timeline from what it was originally written as annually. So we have changed that in 5.2.1. We've added additional ways to complete the assessment requirements, and that includes third-party assessors, use of a community assessment completed for other state agency requirements. So if you're involved with other programs or anything like that through other state agencies, you can absolutely use those community assessments. And then also use of assessments completed by the BHA or a designee of the BHA. Oh, BHA. Oh man, can't talk today. And then 5.2.2, we've increased the timeline for community assessment to every 3 years. That also mirrors what Victoria spoke about earlier in the governance changes, again, to decrease that administrative burden. So those are the changes that we did specifically to Chapter 5, and I will send it back over to Tom for any questions on this section.
Looks like Tom may have stepped away, but I am not seeing any current questions open. Going to hold that for a few more seconds.
I think one just came in the Q&A box.
All right, yes, there's a comment, community assessment still remains an elusive construct. So yes, thank you for that comment. I think we are continuing to envision what that looks like. Of course, this is our first step in this direction of getting this chapter up and running and really envisioning these community assessments. So we will continue to provide guidance on that and appreciate your comment. All right, I think we're ready to move on to Chapter 6. All right, thank you very, and I'm gonna mark that question. I'm still navigating the Q&A tech here. So we'll go into Chapter 6, Behavioral Health Recovery Supports. So this is applying to agencies.
Hi, sorry, this is Marina. I apologize for interrupting you. I saw that someone raised their hand, and I just want to make sure they're not able to like type in a question. We give them an opportunity to ask the question, if that's okay.
Sure.
Okay, thank you. Sorry about that. Renee Johnson, I'm going to unmute you and you can go ahead and ask your question or make a comment. Go ahead. Yep, you should be able to unmute your mic. Okay, maybe some technical difficulties. Renee, go ahead and maybe put your comment or question in the chat or keep it up and we'll maybe try it again if you're having a little bit of a difficulty. Okay, Victoria, you can probably go on.
All right, thank you. And just doing a time check, we're at 12:09 and I think we're about halfway through. So we're going to try to make sure we're getting through all of our content today. So now I'll be talking through Chapter 6, Behavioral Health Recovery Supports. Again, our first go at writing these regulations for peer support professionals employed by agencies into our rule volume. So this applies to agencies providing recovery support services rendered by peer support professionals, but to be clear and to the point made earlier, this does not include RSSOs. That is a separate license and separate chapter of rule. So just wanted to start this out by saying that we have very engaged stakeholders in the peer support professional community, and we held an additional stakeholder feedback session on December 20th in order to dive into some more specifics and make sure that we're really moving in the right direction with this chapter. So for those of you who participated in that extra section, really appreciated you being there. I think we had a really great and productive conversation that has informed the updates I'm going to share. So again, that focused on topics of role and scope of peer support professionals and the supervision structure attended by peer support professionals, agencies that employ them, advocates, and also healthcare policy and financing, our partners at HCPF. So we talked specifically about the scope of peer support professionals, and the feedback that we received was we had this language added in that peer support professionals should only be operating within their scope, but it was unclear whether we were holding the agency to that standard or the individual peer support professionals to that standard. So we wanted to make sure that that was clear and also work on moving toward defining that role and scope of a peer support professional. I would also just like to do some level setting here that we are, again, moving into this space. I think we have lots of opportunity to continue to develop specificity in the future, but what is included here was what I really heard agreed upon by this group when we met, that these felt very clearly outside of the scope. And so we added this language that agencies endorsed pursuant to Chapter 6 must ensure, so the agencies must ensure that peer support professionals are not required to provide services that compromise the dynamic. So being clear that that is not falling on the individual peer support professional. And again, not providing services that compromise the dynamic of a peer-to-peer relationship or that are outside the scope of providing recovery-focused services. And again, we talked at length in that meeting about what falls outside the scope of a peer support professional, and what we really came clearly to a conclusion of was that performing clinical or diagnostic assessments and drug testing are outside of that scope. And those are things that we hear happening current state, and wanted to make sure we're really clear about that in rule. We also received stakeholder input that the BHA should require submission of job descriptions for peer support professionals to ensure that the scope is appropriate. So this requirement was added here, that agencies endorsed pursuant to Chapter 6 must submit those job descriptions of peer support professionals. And there's some language in the BHE Chapter 2 about that process as well. So we just referred to that here. There was some recovery coaching language initially included, and we received feedback, actually quite a bit of feedback, that it didn't really make sense to call out recovery coaching and qualifications for that separately, because recovery coaching is really broad and encompasses many different recovery support activities, and the language wasn't very helpful or clear. So we removed the two places where we specifically named recovery coaching. We removed those from the rule language. We also have heard about a desire for flexibility in peer support professional supervision models, specifically requesting that peer support professionals be able to supervise other peer support professionals. So we do intend to support a variety of models of supervision structures for peer support professionals, and want that flexibility and those models to be reflected in rules. So this language reads that peer support professionals must be supervised on at least a monthly basis by a licensed mental health professional in good standing and or an experienced peer support professional. Again, leaving that open for different models that we know exist throughout our agencies and the provider community. So for the purpose of licensing, this flexibility is included. That comes with the disclaimer that Medicaid will provide billing guidance about what is required for billing peer support professional rendered services, who needs to sign off on those, but that is not really within the scope of our licensing authority. So we want to be sure we're allowing for that flexibility in this space, and then for those agencies billing Medicaid, that billing guidance lives with Medicaid. So pause there for questions. I'm not seeing any open questions.
Victoria, I want to just emphasize something which I think is a really great question that I just closed around what is the requirement of peer support professionals who may be, providing their needed services outside of the recovery support setting. So what is their role in crisis? And so just want to emphasize the answer I'm typing here, which is that, while Chapter 6 specifically refers to recovery support, the other endorsements such as crisis do articulate that a crisis professional can provide those services. And we simply define a professional as someone who has completed crisis training And so it does not exclude peer support professionals. The BHA's goal is to release this training for the state so that we're all on the same page on what we expect for crisis professionals. Hope that helps.
Thank you so much, Dr. Medlock. Appreciate you bringing that up to clarify. I just see one other, more of a comment, but I'd love to share. Thank you for the flexibility in peer support supervision. Happy to provide that flexibility and support the peer support professional community in that way. So thank you for your comment and your engagement. All right, we will move on to Chapter 7, and I will hand it back over to Mel.
Great, thank you so much, Victoria. Hello again, everybody. So Chapter 7, Behavioral Health Outpatient Services. This does include early intervention and outpatient services, and this applies to agencies providing behavioral health outpatient services. One thing that we needed to clean up from stakeholder input was confusion around the minor in possession and that it wasn't defined in that section. So we added two definitions to that 7.1.1, the first being minor. And so minor for the purposes of this section means an individual aged 20 and younger. We also added the definition of minor in possession. Minor in possession, or MIP, is the legal terminology used for an offense that is issued to individuals aged 20 and younger for underage drinking or possession. MIP may result in a revocation of a driver's license, a substance use disorder assessment, and/or alcohol education and treatment classes per section 18.12.122 of Colorado Revised Statutes. So because the way that the structure is in this chapter, I included the service and delivery setting for both early intervention and outpatient services. So we received input on both of those sections that there needs to be continuity on telehealth provisions and also a concern on not having anything about group size. So our response was that we added clear direction of telehealth standards in linking back to Part 2.9 for those telehealth regulations. We also added a cap to treatment groups to not exceed 12 people. Similar for the personnel qualifications in that it is both under early intervention and outpatient services. So that Part 7.1.5 and 7.3.4, we received feedback of needing overall clarity around personnel and staff versus supervisor consultation requirements. So our response for that consultation requirement is that we changed the language from reading staff to staff, which is how it is currently in the current 502 regulations, to agencies providing services shall ensure treatment personnel have supervisor consultation available within 24 hours via in-person or telephone to discuss, when warranted, at minimum psychiatric or medical concerns of individuals receiving services. Personnel shall have supervisor consultation available within 1 hour via in-person or by telephone to discuss, when warranted, crisis emergency situations. And then Mariana discussed the changes that were made in the personnel section, and those were reflected in the changes in 7.3.4. So I won't repeat that information since she reviewed all of those definition changes when she talked about 1.3. Documentation requirements. So there was a need for clarity around documentation requirements for the outpatient services chapter. Again, the how for general completion of the document is in Chapter 2, as Jenna discussed earlier, and the when to complete is found in the endorsement. So the completion timelines in 7.3.6 for outpatient services are screening upon entrance into services, the initial assessment within 10 calendar days unless urgent need is found within 1 calendar day, initial service plan within 14 calendar days after completion of that initial assessment, and excuse me, and the service plan update upon change of individual level of care or functioning, or at a minimum of every 6 months. The comprehensive assessment within 60 calendar days from the first date of services, and then progress notes are completed at a minimum frequency of 1 note per session. Okay, and I will pause there for questions and hand it back over to Tom.
Thank you very much for that, Mel. I see that we have a question from Carrie Swenson, and I'll attempt to respond to that right now. Ms. Swenson, I certainly do understand the concern about the requirement for 50% licensed staff, particularly in the current climate with it becoming ever more difficult to recruit and retain trained and licensed staff, perhaps exacerbated in frontier and rural areas of Colorado. This rule is one that is a carryover from the current state. So hopefully that's not a surprise as far as that goes. I would also say that this has been a particular rule that has gotten, maybe not if most, but certainly in the top couple of rules that we're putting out there, stakeholder feedback. And interestingly enough, at least to me, depending on the stakeholder group, we've gotten similar responses from providers that share your concern about this being an onerous rule that potentially puts small providers in particular at risk of closure, but also some concern expressed by other stakeholder groups that allowing this many unlicensed staff puts people receiving services at risk. So we are really in the middle as the regulatory agency and doing our best to protect those people receiving services while also being aware of the difficulty of providers, again, small and rural frontier located providers in recruitment and retention of staff. So we understand that this is uncomfortable for a lot of stakeholders, and as a result of that, for most service definitions are keeping the rules that we currently have in place there. Now, we understand that that doesn't necessarily solve the tension on either side. So it's something that we continue to talk about. It's something that we continue to think carefully about when we get additional comments like this, either in these meetings or frankly, we anticipate that this will come up in formal rulemaking hearings. So we will proceed accordingly. And then the last thought I have about that is something that we intend to address in the future, as we've said many times in our public stakeholder meetings. These rules don't get approved and then we're done. It will be a constant process of revision and improvement. I was not keeping up with chats or Q&As as they came in. Victoria, anything else that you saw that came up, or anything else that you would care to add to my previous response?
I don't think so. We have a couple of other follow-ups, just kind of along the same vein of the licensing requirement. There were a couple of other questions that Dr. Medlock answered regarding group size, and that being the 12 participants, not including the personnel. So I'm not sure if we want to continue down this path or keep going. I will note that we're at 12:24 and still have a number of slides to get through. So we'll look to you about how we want to address.
Thank you, Victoria. I think I will take this last question from Pam Craig at this point. I think the other comments, I would invite folks to reach out and speak with me specifically, or continue to send in rule feedback. With regard to regulatory waivers, yes, we do consider regulatory waivers. It's a rule about other rules. So there's an application that's located on the BHA website. Any current licensed or designated provider is welcome to send in that regulatory packet, and the BHA has a statutory responsibility to read and respond to that rule packet within a specified period of time. It is, of course, no guarantee what I'm about to say, but we have granted waivers in particular for rural and frontier areas that are having a problem with staff recruitment and retention. Of course, it must be said that our primary responsibility as the Behavioral Health Administration is to determine through that rule waiver process that the health, safety, and welfare of any recipient of service is always protected at all times. So and outside of this particular rule in question, we have to make sure that that question is answered whenever we consider any regulatory waiver. So I just wanted to give that additional details. I think that particular had not come up. And I think with that, to try to give us the best chance of getting through the other updates, we'll turn it back over to the team to move on to Chapter 8.
Great, thank you, Tom. So Chapter 8, this will actually be pretty quick because a lot of the changes were very similar with Chapter 7. So Chapter 8 is high intensity outpatient services. This includes IOP, intensive outpatient program, and PHP, partial hospitalization program. So this chapter applies to agencies providing those high intensity outpatient services of behavioral health treatment. So again, changes are very similar, added that limit of 12 individuals to treatment groups. And as Dr. Medlock answered in the Q&A, that is 12 individuals receiving treatment. That does not include the therapist. Personnel changes were made to match those 1.3 changes that Mariana spoke on earlier. We also updated the supervisor consultation language that I spoke on just a few minutes ago, and documentation changes in that part 8.1.8 for IOP are just exactly as I described earlier for the outpatient timelines in Chapter 7, and in part 8.2.8 for PHP. Screening, assessment, and service plan are similarly changed to the IOP and the Chapter 7 requirements, but progress notes for PHP services are different in that minimum frequency of 1 note per session and 1 progress note per week. And that actually matches the current CCR 502-1 regulations for progress note documentation completion. Those are all the changes for Chapter 8, and I will hand it back over to Tom for questions.
Thank you for that, Mel. And recognizing that we are probably running short on time, we will do our best to continue to respond to Q&A questions. And if we are not able to answer all the Q&A questions, that we will also attempt to get back to people submitting questions through the BHA rule feedback, and also personally make myself available if folks want to reach out to me via email as well. So let's move on to the next Chapter 9. There we go.
All right, that will be me. Hello, everyone. So I'm going to walk us through some of the changes that we made since the first presentation on behavioral health residential services. So this will apply to agencies that are providing residential care to individuals living with substance use, mental health, or co-occurring disorders. So Chapter 9, one of the areas that we received significant amount of feedback on was around the house rules requirement. So as you can see, looking at the input that we posted here, we got a little bit of a mixed bag. There was, stakeholders who really thought that the strongly empowered individuals that were receiving the services better prepares individuals to return to community. If we're going to be going down this path, we should also include tobacco, but then also concerns that adding this requirement in could be considered punitive and could possibly not match every level of residential care. So in response to this, what we did was we removed the house rules as a definition, but still left in the requirement for completion of house rules, removing the publicly visible requirement and adding tobacco and vaping for consideration. updating the proposed frequency to the agency shall develop and follow a schedule for revisiting and updating house rules and shall allow for collaboration and feedback from individuals. So the hope with that is that will be flexible enough that it can match the level of care and the acuity and intensity of the population that's being served. So the house rules and the development of that, or the frequency it's revisited, may look, different for a low acuity facility versus a medically managed high intensity or high acuity facility. So for Chapter 9 as well, we received a good bit of feedback around, strengthening the foundation of this chapter, which was very much appreciated. So the stakeholders let us know that we really appreciate the emphasis on coordination of options for individualized services and prioritizing the whole person services for individuals that are receiving care. However, the chapter was confusing as it was originally proposed. And so we've done a good bit of work of trying to restructure Chapter 9 to be more clear and to strengthen that foundation so we can continue to build this out together. So as you can see here, the response was restructured to identify requirements that are applicable generally to all behavioral health services that are received. So mental health, SUD specific or co-occurring, which we're looking at as a combination of both of those requirements. And then we have suggested a new grouping by acuity levels of the individuals that are receiving services. So the low acuity residential services would include on the SUD side be akin to an ASAM 3.1 and an ASAM 3.3, and then also have a mental health focused home or residential facility that would be of a similar low acuity level of care. Again, if you're going for co-occurring treatment, that could be the combination of both of those. Medium acuity is following a similar vein. That would be around an ASAM level 3.5 for SUD specific services with a mental health equivalent of a medium acuity need. And then high acuity, we're grouping with the ASAM 3.7 as well as the mental health equivalent for that higher acuity services. Okay, so this chapter in particular, we did receive a good bit of feedback, and hopefully when everyone takes a look at it, we'll see some of the improvements that were made there. There was some clarification that was requested around personnel. We got 2 pages of it, actually. That's why we have this kind of separated out here. And really great question. So is a peer support professional considered part of the new definition of a group living worker? The ratio requirements, we talked a little bit about what this would look like per agency versus per site. Is there a supervision focused option? And there was some feedback received around the minimum ratio of 20:1, the way that it was listed in the first proposal, looking like it was only nights and weekends. And what does that mean for smaller sites? So a lot of really important feedback there. What we've responded with is we've updated the definition of the group living worker to clearly exclude peer support professionals. That is a separate definition, that is a separate category. We want to make sure that we are treating it as such. As mentioned before, with some of the other ratio and percentage requirements that we have talked about, our intention was to keep similar ratios as they exist in current rule at this time, with the plan to come back and revisit that, because we did receive a lot of feedback on that, and we want to make sure that we're responsive to that. We've also added the language of at all times to the minimum supervision pattern so that it no longer looks confusing that the minimum ratio would only apply to nights and weekends. And then going along the lines of personnel input for Chapter 9 again, there was a distinction that was requested between the types of personnel and what that would look like for the management of a milieu, and again, adding treatment options to personnel. So this is one that we built upon with the regular traditional definitions in Chapter 1, example, adding a physician assistant to the authorized practitioner definition. So really there is a significant restructure that occurred with this particular chapter to make this work. Treatment personnel, we have all behavioral health that is included in the original category. When you look at it, that would encompass both mental health and SUD, and then it pulls out SUD specific personnel. Specifically on this one, I would point out a certified addiction technician, since that is specifically SUD related. And then we encapsulated a section that talks about milieu management personnel options, which would include those peer support professionals as well as the group living worker. So hopefully more consistency, and it reads a little bit more smoothly as we're going through and building out the rest of this chapter together. Regarding Chapter 9 and documentation and timeliness inquiries, so we had requests to clarify the benchmarks for documentation completion. We had some say that the timelines were too stringent, and on the opposite side, some feedback that the timelines were possibly too lenient. There were concerns about the transition from business days in existing rule volumes into the proposed language, moving to calendar days, and what the frequency of progress notes across levels of care and residential look like. So our response to all of these was we have restructured the section to more clearly reflect those benchmarks, and the majority of them start from the time of admission to the facility. We have kept the current timeline for comprehensive assessment completion aligned with current rule, noting that it has transitioned from business days into calendar days. So it moved from 7 business days to 10 calendar days, which is hopefully pretty well equivalent. And the original language that we put out had requested daily progress requirement, and that did not one-to-one match with current requirements, which did allow for some weekly documentation for certain levels of residential care. So the proposal that we have here is the low acuity facilities that we had mentioned. That would be a minimum of a weekly progress note. Medium acuity has a little bit of a bit of a distinction here with if it's a short-term stay in this medium acuity facility we have defined right now as of less than 3 months, that would be required to be a daily documentation. And if it's intended to be or expected to be more than 3 months, a minimum of weekly. Again, can certainly do more than that, but minimum of weekly at that point. And then for high acuity, the requirement proposed is daily. And then some of these were already addressed, so I'll go pretty quickly over them, but stakeholder input, making sure that MAT services are not going to be a barrier to admittance. That is new information. So we did add that information to Chapter 2 that should be more broadly applicable. And so we wanted to make sure that that was captured. Current utilization of medication-assisted treatment or interest in beginning MAT services is added and cannot be the sole reason for treatment ineligibility. And then, as Victoria mentioned earlier, we did clarify around advanced directives that we had mentioned in this chapter, changed it to psychiatric advanced directives, and did specifically for residential, found utility in having the residential personnel available to help complete if clinically appropriate and the individual is interested in learning more about their psychiatric advanced directives. And then I think for Chapter 9, again, lots of feedback on this chapter. There were some that believed it was not closely aligned enough with ASAM requirements, was not exactly clear what was expected at the level of care. And as we're adding in these mental health equivalent and really trying to pull together behavioral health residential services and making those align, that it was not appropriate to use ASAM requirements as the anchor for those mental health services. So I believe that what we're putting forward here will hopefully get us one step closer to making that work and to give a foundation that will help support that growth over time. Again, there's some new things that we're proposing here, and we expect that they will ebb and flow, and we will continue to develop them together. Many of the ASAM specific requirements that were updated in 2020 were carried over into the suggested language. And again, we'll just continue to solicit input and continue to build this together as we go. I will hand this back over to Tom. We are at questions.
And Mariana didn't have the advantage of seeing our behind the scenes chat. Because we are super pressed for time, we're going to pivot and just continue to present and again, do our best to keep up with those questions coming in through the Q&A. Thank you. Chapter 9.
Thank you. I'm going to dive into the final part of Chapter 9, which is the mental health transitional living homes. So we did make a couple of updates here. So we received input that some of the requirements in this section should apply across residential and overnight settings. So we took emergency preparedness requirements that had been built into this section, and we moved those up to 2.26, which are the residential and overnight requirements that apply to all BHEs, providing a level of care that includes residential or overnight, so that those are standardized across overnight providers. And then there were also some feedback about controlled medication requirements, possibly being contradictory with DEA requirements. So we did review those medic administration rules. The med administration rules that did previously live in this section were also moved up to Chapter 2, again, to ensure that there is continuity across the rule volume. And we did review for alignment with DEA requirements. So hopefully that has been resolved in that way. There was also some requests to add physician assistants where physicians and APRNs or advanced practice RNs are referenced. And we did adjust our definition of authorized practitioner to clarify the role and applicability across the rules section and ensure that physician assistants, APRNs, and physicians were all included. So when you see that term now in this section, it does apply to PAs as requested. And then finally, we had some stakeholder input regarding concern that the admission or discharge criteria would impact the care of individuals who display challenging behaviors in these settings. That was certainly not what we were attempting to do with the rules. So we removed the section that discussed exhibiting conduct that poses a danger to self or others, and the agency is unable to sufficiently address those issues through therapeutic approach. And we just emphasize the latter process for addressing the changing needs of individuals outlined. So it's in that that following part of those admission and discharge criteria, which is now Part D, and that removes any suggestion that these facilities are not designed to meet the needs of individuals who may exhibit challenging behavior, and instead emphasizes that process that agencies are assessing changing needs and adjusting service plans as needed to ensure the ongoing safety and care of those individuals. And I'll pass it over to Olivia to jump into Chapter 10, and we'll continue to address comments in the Q&A.
Thanks, Erica. Next slide, please. Thank you. All right, so for our general changes, we did add a kind of broad definition of the crisis assessment. This means a standardized assessment form created by the BHA. Again, all agencies providing any type of crisis service to individuals that may be placed on an emergency mental health hold have to complete this form. We also received stakeholder input on clarification around advanced directives, and I think Victoria already touched on this, but throughout Chapter 10, it now reads as psychiatric advanced directives. And then moving into our walk-in crisis services changes, we received input to include brief intervention, stabilization, and de-escalation intended to maintain stability in the community whenever possible to our WIC services, not just the mobile crisis response services, and we did add those in there. And then we also received input to define immediately or change/add the time frame to personnel requirements regarding access to a licensed mental health professional via telehealth if not available on site. So this part now reads as a walk-in crisis facility must have access to a licensed mental health professional available via telehealth within 15 minutes if not available on site. So it is no longer immediately. All right, mobile crisis dispatch changes. We received a lot of input regarding just clarification on response time start. So is it the call time versus the time of dispatch when the mobile responses have to be done by. So mobile crisis response teams must arrive at the community-based location where a crisis occurs within 2 hours of accepting a dispatch request for rural and frontier areas and within 1 hour of accepting a dispatch request for urban areas, including dispatch from the statewide hotline /988, either face-to-face or using telehealth operations as part of a paired response where allowable. And then lastly, for respite care service changes, we stakeholders wanted clarification around what outpatient respite services are. We did just kind of change the language. So it's no longer outpatient and in-home respite care services. It's just residential and community-based. They also wanted provider length of stay. Provide length of stay information. So we have length of stay determinations must be ongoing, transparent to the individual and family, and jointly determined by the individual, family, respite provider, and treatment team. Stay shall generally be no more than 20 consecutive days. And then lastly, we have clarification needed on who medical professionals are, or what is meant by medical professionals within their scopes of practice. This has been removed and is now residential or community-based respite care services provide temporary or short-term care by licensed and or unlicensed mental health professionals or personnel based on the level of care being provided to an individual that has experienced a self-defined crisis. I'm going to pass it back to Mariana.
Okay, thank you, Olivia. All right, so we're going to run through withdrawal management, which is chapter 11. So again, highlighting what changes were made from the first iteration that was put out. There was a request to clearly exclude hospitals from this chapter requirement and to allow the new ambulatory withdrawal management levels of care 1 and 2 that we were putting forward to treat benzo-specific withdrawal. So the response was we did add language to clearly exclude general hospitals that are operating under their existing license, and also modified the diagnostic criteria for level 1 and level 2 withdrawal management to the following language in response to the feedback that was received. Regarding chapter 11 and the medication assisted treatment specific section, there was stakeholder input that was received around the federal rule and referencing the federal rule for utilization of controlled substances to treat opioid withdrawal or opioid use disorder. So again, in conjunction with the state SOTA, we have put forward the language of adding in a definition of 72-hour emergency rule and references this particular allowance for the qualified practitioner to provide controlled substances to individuals experiencing acute opioid withdrawal symptoms daily for no more than 3 days. And this will carry over as a shared definition that will apply to the controlled substance chapter as well. Stakeholder input, going a little bit further, was again connected to aligning some of that language. We aligned the qualified practitioner within this chapter 11 with chapter 19, as I just mentioned, to make sure that those are operating in tandem, and added the language of withdrawal management facilities shall be knowledgeable of and comply with the provisions of this 72-hour emergency rule when treating individuals who are actively withdrawing from opioids. All right, and moving along, there was again that request to include more personnel to be able to provide treatment services. I think we've captured that pretty well. And a recommendation to add mental health and physical health pharmacology as needed to permissible therapies. So we've already aligned those definitions and included those providers and added the suggested language as indicated above. And I will hand it back over to Olivia, I believe.
Thank you. All right, this one's quick. So just wanted to note that endorsement language was added for both emergency and involuntary SUD commitments. Again, this is an optional add-on endorsement for agencies that want to be able to provide services to individuals on these commitments. And then we did receive stakeholder input regarding BHA custody authority. So we did align this with statute and clarified that the BHA may delegate physical custody of individuals involuntarily committed to treatment pursuant to section 2781.112.5 CRS. And then we also received input to add discharge summary requirements to the emergency subcommitment section, which we did add. And I will hand it to Jenna.
Thanks, Olivia. So I'm going to go talk about Chapter 13, Children and Families. As Victoria alluded to earlier in definition section, we had to change, or we removed the term youth from the Children, Youth, and Families endorsement to just Children and Families endorsement, as this chapter is really applicable to anyone under the age of 18. And in children, in the Children's Code in 19-1-103 CRS is where the definition of child is anyone under the age of 18 and youth as anyone under the age of 21 resides. So we did keep the definition of youth in our rule volume for the sake of CYMHTA and RCCS and anyone else that still needs that definition. But this chapter specifically is for anyone under the age of 18. And then there was some stakeholder input of why wasn't a clinical social worker candidate included. And we changed the language to include social worker or clinical social worker candidates into professionals that are able to treat children. Next slide. And then one of the question or stakeholder input was clarification around who's asked to help create the service plan and if it needs to be signed. And our response was we added a little more clarification in 13.1.4A1. The service plan shall be developed in collaboration with the child's parent or legal guardian and signed by the child if they are over the age of 12 and the parent or legal guardian. In the event that the involvement of the parent or legal guardian is contraindicated, the rationale shall be documented. And then there was concern over the providers, who the providers can use for fingerprinting per Senate Bill 17-189. And our response is that agencies will continue to be allowed to use different entities for background checks as long as they are comprehensive in order to serve children and families. So what was allowed under Senate Bill 17-189, we are still allowing. And then there was the internal and external about the ACEs screening, and we have added a definition for the ACEs screening and then having that included into comprehensive assessment for children. And then I will move right into Chapter 14, Gender Responsive Treatment. So we removed, there was some concern over the addition of the definition woman and asked for replacing that term with individual. And so we have removed that definition of woman, and to increase inclusivity, language has been added in Chapter 14 to say pregnant and postpartum women and or / individuals. Due to federal regulations from Title 45 CFR, for federal block grants, we still need to use the term women in certain areas, which is why we have women / individuals to be more inclusive. And then changing the usage of the term substance use to behavioral health throughout the chapter.
Okay, and that's back to me. Chapter 15, Outpatient Competency Restoration Services. This applies to comprehensive community behavioral health providers that have to provide that service. The changes were minor. The feedback that I received was really just grammatical changes to add more clarity. And so I took in that input and made those changes. Otherwise, there were no changes to regulations or standards for this chapter overall. And I'll go ahead and continue on with Chapter 16. So this is for criminal justice services. The changes were specific to adding in peer support professionals and to consider mentor involvement in the existing model for therapeutic communities, or TC. So we added that language for peer support professionals in the criminal justice chapter, and we added treatment involved mentors to the definition of personnel reflective of the current TC practices. So that's 1.3.16, and we added it on at the end of that definition there for personnel, so volunteers or treatment involved mentors. And I will hand it back to Tom.
Well, thank you very much, folks. I think we have essentially done it. I would like to take this opportunity to first thank all the members of the Safety Net team, and in particular, Victoria Lasky for her leadership of that group. This has been a tremendous effort in a very short period of time. And I'm so proud to have been part of this effort. And and part of the team that made this historic moment happen. I would also like to take the opportunity to thank all of you, the stakeholders that helped us improve these rules. We believe this is an important first step in improving behavioral health services in the state of Colorado, and we appreciate the opportunity to engage with you in the 5 previous stakeholder meetings and in this rule replay. With that, I'd like to turn it over to Dr. Medlock to make any closing remarks.
Thank you. My heart is just filled with gratitude for this moment and thankful for everyone who showed up today. I think this is incredible what we have accomplished together as we co-create this new reality where services are accessible, meaningful, and trusted. With every decision, I've tried to balance my own identity as a psychiatrist who deeply cares about individuals who are seeking their well-being, with also thinking about what is in the best interest of the people of Colorado. So as we balance those identities for provider, for those who are in need of services, for our advocates across the state, we hope that you can sense the desire to find balance in this rural volume. I want to reemphasize that we started with something that is really important. So for those who joined the call late, what we are proceeding with at this time is the behavioral health entity licensing chapters. We will engage in further stakeholdering and improvement of the sensitive issues around care coordination and safety net approval, specifically for providers that may not be directly regulated by the BHA currently. So stay tuned for that process. We will do additional rule replays so that we can ensure that we are all on the same page. Finally, I want to share that there was a question in the chat that is remaining. We're researching that question around medication for opioid use disorder education. Thanks again for being here. Back to you, Tom.
Thank you, Dr. Medlock. It means a great deal to us, the amount of involvement that you've had in these rules. I would be remiss if I didn't thank you personally for all the improvements that you made as the Commissioner of the Behavioral Health Administration. You and I have spent a lot of quality time together working on the rules, sometimes late at night, and they are a better product as a result of that. I think we have another slide that will give a bit of additional information about what's coming next, in particular when we present the first packet to the state board. That again is a layover reading or an informational reading. You can see more on the website that's put there on the slide. I don't know if there are any other slides left in the presentation. And I think that we are down to our last couple minutes, so please, we have put it in the chat a few times, but please take advantage of these additional funding opportunities. I think in several presentations ago, Joy Hart, Division Director at the BHA, presented on these personally, but this is here to refresh your recollection. And with that, I'd like to conclude the rule replay town hall presentation. Again, thank you for all that have attended, and we look forward to doing more great things with you on behalf of recipients of service in the state of Colorado. Enjoy the rest of your day.